The question had to do with whether there's an intersection between the IDD and Behavioral Health Services Commission. Actions on as individuals grow older, some of the behavioral health or psychiatric issues that might emerge. So that is a really, really good question. There's a lot of intersection. I'm kind of looking to see who might want to say more about that. I think Amy, we'll have Amy speak to that.
And so over the last couple of years while I've been in this position, I have encountered, seems like more and more individuals that are in need of behavioral health services, but that their primary diagnosis is IDD. It makes it difficult to serve those individuals in the system that we have currently. There is a gap there. If they don't quite belong in a psychiatric hospital, if they need acute mental health services, but yet they need something more than what the community provider might be able to provide at any one point in time. I do have a couple members of my staff that are working not only amongst themselves, but also with Kim Lynch's staff now on the State Hospital Commission and Andy Brown's staff in behavioral health to look at ways that we might be able to bridge that gap and provide a better kind of continuum of care for those individuals with intellectual and developmental disabilities who happen to be experiencing behavioral health crisis or behavioral health issues. So I think we're seeing it, and we're trying to come up with some solutions and some ideas that might work in our system.
Well, the point is that some of these people enter the system, they're IDD, but they also have primary behavior disorders. And as I said, in our CBO, they figure about a third of the IDD folks have this with almost no behavioral health support.
Yep. So it is a very important segment of the population. Mm-hmm. Absolutely. Thank you.
I might just simply mention there are some other states that Washington State has a model that they actually are very focused on some behavioral health options. I think they've even applied, as I recall, I think it's actually a waiver. It might even be a 1915C that's very focused on that particular population where they have some behavioral health options. It seems to be pretty progressive, but we've just recently heard about that particular model in Washington State. But I think some folks on our Amy staff and Andy staff are checking into that just to explore some options. So we appreciate that question.
Yeah. Yes.
So I don't know if I'm a stakeholder per se in the sense that I work with them on a daily basis, but as an elected official in Manhattan, we were able to fund 2 co-responders on with our CPD and Pawnee mental health, and we were able to get some funding for the stabilization center, so that would be a conduit between any individuals that come in conflict with the law to also have a place to go as opposed to just going straight to ER. But one of my questions was on the social determinants of health. What exactly does infrastructure implementation mean? What kind of, are we looking at workforce infrastructure? What kind of infrastructure are we looking at?
Yeah, I'll ask Commissioner Brown to talk more about that. The question had to do with what was meant really by infrastructure improvements as it related to the Behavioral Health Commission. And then there was also some discussion from the Commissioner just talking about the effectiveness of some partnerships that they've been able to do out in the Pawnee area. Yeah. Mm-hmm. Right, but some of the intersections with law enforcement, some of some progress they've been able to make on the forensic side. So I'll turn this over to Commissioner Brown to talk more about infrastructure improvements.
So I'll talk a little bit about what we've been able to do in prevention, and then kind of how that might apply a little bit more broadly. But so with prevention, what we did was we sort of restructured the way the regional prevention centers were set up and how we allocated our funding across the state, so that we created a Kansas Prevention Collaborative, which is basically a backbone of TA provision, community engagement, and evaluation of programming for evidence-based practices across the state. So that looks like community coalitions being able to access those services on a statewide basis through quarterly meetings, which were held around the state, which are face-to-face meetings with other coalitions that are facilitated by our Community Engagement Institute with Wichita State University. We then provide training through our federal TA partners to make sure that people have the appropriate skills needed to do suicide or substance abuse prevention work and problem gambling work in those communities. We help them with developing strategic plans. There's a process for providing TA around their own sort of development and structure of the coalitions themselves, how to do partnerships, how to engage with their community leaders and policymakers, so that there's a strengthening and a building of the infrastructure around the state in those communities that are participating in that process. So and that's the kind of vision that we have for rolling out a lot of infrastructure around the state is that we sort of have lacked a commitment to evidence-based practices. We've lacked some infrastructure around fidelity to those evidence-based practices. So we're looking at ways we can do a better job with training our workforce, developing our workforce, making sure that our communities have access to the types of resources that they need to be able to implement programs effectively within the community. Does that make sense? All right. Was there a second half of that question? No. Okay.
Other questions of clarity, questions in the room?
So I've turned mine into a question. I'm sitting here thinking, isn't that shocking? My question is around employment. So I see that you've got 3 commissions who are saying that employment is a social determinant of health. You've got employment, the work program over at KDHE. I hear talk about a waiver around employment, and DCF has voc rehab. Has there been any big picture planning around employment where people can have kind of a one-stop and can actually go get a job?
In terms of, the question has to do with what kinds of planning is going on across systems related to employment. Well, one of the first things I would say is, there's always been a lot of planning that a number of different stakeholder groups have done over the last few years, and a number of really, really strong recommendations that have been made. I would say right now, it's an area, as you called out, that cuts across both of the agencies that I lead, where there needs to be better collaboration, better communication, better intersections. One of the reasons you see that called out across the commission is it's one of the top priorities that we have as we move forward. Are we there in terms of specific plans at this point? No, not yet. Although you will see some things rolling out soon, for example, on the voc rehab side, the availability of some new opportunities for RFPs and grants that folks across service systems will be able to access. And in fact, there's a meeting, I think either today or tomorrow, where someone from Commissioner Penrod's shop is going to be meeting with our interim director on the rehab services side, our acting director on rehab services with the Rehab Council, and really talking about what some of those pieces might look like in terms of some RFPs. One of the things, not to stay on voc rehab too long, but the state for far too long has been letting way too many federal dollars for that program languish in Washington, D.C., and we don't have enough match today to bring all that down, but these will be some of the first steps. And again, those will be really targeted around, I think they'll be really attractive to individuals across a number of service delivery systems, and then there'll be a second piece that's going to be targeted around transition age. So again, stay posted on that, but lots of conversation and collaboration across commissions. We need to formalize that, I think, a little bit more in terms of some of those goals, and then begin to bring stakeholders back to the table on maybe what some of those top priorities should be, because there's really, really good recommendations in a number of the reports that I've seen since I started, based on the work that many of you have done. So, thank you. Other questions in the room? Yes.
question is, what will the managed care organization's role be in care planning going forward?
Okay, so the question was regarding the provisional plans of care that I talked about during my segment, and the actual question is, what will the role of the MCOs be in care planning? So the provisional plan of care is in and of itself a eligibility function or an eligibility tool. The MCOs will still have responsibility for developing that formal plan of care that will be used to, set the services up for the individuals in the long term. A provisional plan of care is not meant to go beyond a certain period of time. I believe it's 60 days. So it basically allows us to get folks into eligibility a lot quicker. Thank you.
Yeah.
Just wondering about some updates to the mental health regulations for psychiatric licensing as well as the substance use disorder. Both of those are kind of collectively old, and in some cases just not applicable. And also to that end, some of the same conversation around folks with co-occurring illnesses. Can we get our licensing regulations to be more in sync so that we're not operating in silos so much around regs as well as funding?
All right, the question has to do with licensing, particularly in the behavioral health world and co-occurring disorders. Commissioner, we'll take that.
The question about the revision of some of those regulations, they are also on the list, and that revision certainly does need to take place. One of the challenges that we look at and will continue to look at is in defining the categories or the types of licenses, and looking at whether we need to then go back and look at some statutory changes that allows us to do some integration that really is not there right now. But those standards and those regulations are also on the list for review and revision.
Let's check and see if there's any questions from folks online.
We did hook one.
All right.
With initial approval from CMS on the final rule, does KDAS anticipate significant system changes for HCBS programs?
So the question has to do with the final rule and whether KDADs anticipate significant systems changes as a result of the final rule. Commissioner Penrod, you're popular today.
Thank you. Yes, Kansas did just receive its initial approval for its state transition plan as it pertains to the final rule. We are, as we go out this summer, we'll be talking a lot more about the final rule and what that means for Kansas. Do I anticipate significant changes? I actually think that over the last several months, we've been working with CMS on this and working on what some of our site assessment tools need to look like and how we need to move forward. I actually think Kansas is in a pretty good space. There may be some pockets of things that need to change here and there, but I think Kansas is in a pretty good position. There will be more detail, and we can dive into the weeds a little bit more as we come out and start talking this summer. But I think I'm kind of feeling pretty positive that we're in a good place.
On the HCBS 1.5% rate increase, when is that effective?
It goes into effect July 1st. So we are working with our folks at KDHE and the system folks that do all that programming to get that in place. I have not heard that it would be delayed at all, but the actual rate would be effective July 1. Whether it is in the system and billing goes through appropriately, I don't have that on me right now, but we have gotten all of the paperwork and everything done to let folks know what it needs to be. We've calculated the rates. All of that is being loaded and worked on. So the hope and desire is that it be ready and loaded and ready to
When
go.
will we publish those rates?
Let's see. I'll have to get back to you on that. I'm not sure.
Well, because that's important, because
Yes.
obviously there's a trickle down to the million, yeah.
Absolutely. Absolutely. Thank you.
Well, and the other thing is that as discussing it with MCOs, they said it would take 45 days for them to update their systems. So if the rates aren't published today, that means billing can't take place for July until late, and it's going to be a big backlog.
We worked as quickly as we could to get the information together and to get that process started so that we wouldn't have a delay, and we're still hopeful that will occur, and we'll work with the MCOs to the greatest extent that we can to make that happen. So I can get some more information out to folks as soon as I have it in my hands. Thank you.
Can you tell them what that question was?
Sure. The question was about the 1.5% rate increase and when that would be going into effect. And again, the effective date is July 1st, and the goal that we're working towards is having all those rates and everything loaded and ready to go so that it is a seamless transition to the new rate.
All right, another question in the back. I thought it might be.
This is back to the final settings rule. You said that Kansas seems to be in a pretty good space right now. How does that impact Shelter Workshop and other 14C certificate holders?
So,
do you think that is possibly compliant with the final setting rule?
okay. So the question was about the final settings rule and whether Kansas, my opinion that Kansas is in a good position also applies to sheltered workshops and 14C? Okay, yes, 14C holders. And I think that probably if there are, like I said, probably a couple of pockets here and there of things that we'll need to really look at. The feds have a process for additional, like heightened scrutiny is what they're calling it, to evaluate those. And I think our goal is to comply with the federal rule, but understanding that there still needs to be a wide variety of choices for individuals, and we certainly don't want to impede, consumer choice to maximum extent possible. So today, can I tell you exactly what that's going to look like? No, but you'll hear a lot more, and we'll be working with the system and providers over the next several months.
Well, along those same lines, first of all, I want to thank KDAD for putting the brakes on renewing the IDD waiver because there's some real issues in there. And I was kind of wondering, and one of those issues is the day service dollars and the money allocated for supported employment. And so, like you said, we want to provide self-advocates opportunities for choice, and especially with regard to employment. And under the current waiver or the proposed waiver, we've earmarked $110 million for days services settings, but yet at the same time, we will earmark $91,550 for supported employment. And I was hoping, will we have the opportunity to do a little more rebalancing and perhaps incentivize providers to provide competitive integrated employment opportunities for people?
So the question, and I'll have to paraphrase a little bit, the question surrounded whether we have the opportunity as we continue to look at the IDD waiver renewal, whether we have the opportunity to look at how that intersects with the priorities that have been typically established via budget, whether we can align that better with the priorities that we'd like to see moving forward, and with the final rule affording individuals choice employment opportunity, etc. So basically allowing choice, not disincentivizing employment, some of those things. I think the short answer to your question is yes. The little bit longer answer is I'm going to need your help. I am going to need for folks to come to my work group meetings with some real ideas and real solutions about how this can work. You all have been in the field for a very long time, and I need your wisdom. I need you to bring that to the table and not only tell me what's wrong with what we have in the waiver right now, but how do we fix it? How do we get to where we need to be?
As Susan said, how do we sign up?
Okay. Send me an email. I'll be happy to have you. Thank you.
One more. This might be you too.
Might get an award or maybe a punishment for asking the most questions for you as well. A lot of us are having a problem with the care coordinators, the MCOs determining the plan of care, and rather than the case managers who are really much closer and have a better idea of what the service needs should be. How do you reconcile that? Because there is an inherent conflict of interest when a person who's working for a for-profit health insurance company is determining the care, because the incentive is to reduce the number of hours of care, and therefore harming the services because that's more profit for the person served. I've heard one answer, which is, oh, the MCOs are going to be more efficient, and it's going to be, they know better about what the hours of care are, and we don't buy that.
The question was about the MCO's role in care planning and the potential conflict of interest that those MCOs have or those care coordinators have in determining individual services while at the same time working for a for-profit MCO. And I would think community service coordination. I mean, we've been working on some new things that may bring some of that back a little bit to the kind of more of local entities. So I will actually let Janice has talked a little bit more about this than I have and been a little bit more involved, and I'll let her explain.
Yeah, so I think, as you know, at one point in time there was some conversations around community service coordination where we would look to some local folks to help do more case management, if you will, and that was at one point talked about and then pulled back and then talked about, and we'll just go ahead and share with you. We're talking about that again. It's still pretty internal, so we're not ready to say much more other than we hear you. We hear you, community service coordination. That whole idea did come from this agency at KDADS, and I hear you as far as targeted case management and community service coordination, if that's where you're headed. We hear your concerns. I will share with you, Secretary Howard and I and our folks, we have a lot of conversations about managed care organizations with HCBS. We talk about this every single day. We want to make sure we understand their role, the role of local individuals who assist with case management, the potential for other ideas. So at this moment, on this particular day, we would just simply say, we do feel like there are some opportunities where we could improve case management more at the local level. Unequivocally, when KDH&E and KDADS went out several years ago, they heard from consumers that they don't know the names of their case managers like they should. And specifically to several waivers, they lost case management along the way. So we hear you. Laura and I talk about this constantly, along with Amy and others, as far as and some folks at KDH&E, is how do we make sure we get that local case management.
Lots of people have already the targeted case managers.
Well, and I'm talking more global. I'm talking more. No. We hear you. I mean, we want local case managers, not. I mean, there's always going to be a link with the care coordinators. The MCOs are here, and there's always going to be a link with the care coordinators. But could we do more? Again, at the local level for case management, and we continue to have those conversations.
So we'll stay tuned.
Stay tuned. Thank you.
And I would just add to that too, that KDHE as an organization as well, the Medicaid agency. I mean they're on board with some of these approaches where we want to go. We're working very well together, in working on some of the challenges and issues that are out there with managed care. But we share a common value of what I like to call high touch and community based. And so, again, there's a lot of things in conversation that in a lot of different avenues around high touch that you'll see rolling out. So, any questions from? I want to go. Nothing. Okay. Yes.
Yeah, I guess what I'd like to know, it's a you question,
Okay.
Mary, is which one of the commissions you are going to place in the lead for finally developing a comprehensive state homestead plan for people with disabilities, bringing us in full compliance with ADA?
The question is about Olmsted. One of the things that I think is really important, and I hope everyone in this room agrees with this, but the opportunities for individuals to live in the community, to have their choices honored and to afford those full opportunities is really, really significant. Olmsted's, gosh, it's been around a long time now. I don't have an answer for today on, gosh, who's going to write a plan, but I actually think that it would not be in the best interest for me to say it belongs in Commissioner Penrod's commission, or it belongs with Commissioner Brown, or it belongs with Commissioner Lynch. This is a value that we have to hold across everything we do. And many of the plans that we're talking about, those are really about, making progress as it relates to Olmsted and what Olmsted stands for and represents. So if you, I would say hold me accountable, but know that, that's a thread that has to go across every single thing we do, and know that is a value that we hold very, very dearly. And I think that's a Kansas value. And I think, one of the things that I'm just really committed to is, there was a time in this country when people talking about issues to do with individuals with developmental disabilities or physical disabilities or behavioral health said, look at what Kansas is doing. And I want to, when I leave this role, I want people to say, look at what Kansas is doing. That's new ideas, that's innovations, and it's really with that whole value, Olmsted being one of those very significant values underlying that. And I'm convinced that with collaborations with folks in this room and across the state that we can make that kind of progress.
Well, I don't disagree. It's just as I look at the issues here, I look at the issues here, I look at the issues here. And really, what is the common theme? The common theme is we have this system that got developed in this bucket. The value, I absolutely agree that the value is important. But I think that rather than having a system that was raised on that value, we have a bunch of systems that just grew up. And it's time for, at some point in time, we've been asking, I've been here for 16 years, we've been asking for this. Olmsted's been around since 1999, so. Where, the federal government said, hey, states, you guys should not just have the value, have the plan. And so that's what, when I look at this stuff, I look at the DRC report, I look at, kind of all the things that are going on, I look at a state where we really are a shining star. The only state in the country that says priority service population, people most at risk of institutionalization. Yet, our MFP project is kind of came and gone. You can look at the numbers, you can look at you can look at where we're at, and you're right. We could be doing better. We should be doing better, but we have to have a plan to do better.
So I'm going to take that maybe as our first shift from maybe a question to an input in terms of priorities, because I'm really hearing you say you'd really like to see us have a plan that we're working from around Olmsted, and that's not a new conversation. So I want to capture that. Actually, Connie's already been capturing a number of things for us, so let me capture that, because as you said, you can see those threads, but I appreciate that, that piece of, I often say to folks, if you don't know where you're going, you're not going to get there, and I think you're trying to make that point with regard to Olmsted. So we can still take questions, but I sure want to shift this as well, although I think folks have figured out a way maybe to combine both these things, but if you haven't, what reactions to priorities that we laid out, other things, if you were the KDAD secretary for a day, what would you add to the priority list that's up here, that you've heard us talk about, what was missing there that you'd like to see on that priority list? In the back of the room.
So one of the questions I have is housing. It's the first thing on the social determinants of health, but I haven't heard anything about housing. That is certainly a crisis. So what is your department going to do to help with that?
So I'm hearing, so you'd like to see a little bit more focus on the specifics of what our department is doing around housing. And there clearly are a number of things going on in housing within this agency. Particularly within the Behavioral Health Commission, but it's an area that we recognize there needs to be more. One of the things that I'm going to do personally is really some outreach to other state agencies to reinvigorate some things that used to be in place a few years ago in terms of collaboration around some of the housing resources and what some of the state priorities might be around housing, as well as looking at communities, and some communities have done a great job of being effective in drawing down some really targeted housing funds. But that's kind of been, having the right people at the table locally. Maybe you've got a really innovative person who maybe runs the local housing authority, and they're working closely with the person who runs the CMHC. I want us to look at that more systemically as a state. Again, so a big priority, but I think one of the pieces is reinvigorating some partnerships and collaborations that were in place, 10 or 15 years ago as a start. So we got housing up there. What else would you like to see on the priority list?
Yeah, so given the emerging trends really that are well in place now, continuing substance use disorder rates just going up and really causing havoc, frankly, and impacting many of certainly the issues that we've been talking about today. I guess if I was secretary for a day, I would like to see that show up more on the priority list. It's not a secret. We've always kind of been a forgotten program, if you will, that never got a lot of attention, certainly never got a lot of money. And so I think, if you look at the national trends, Congress heard more hearings on substance use disorders this year than in the last 30 years than all 30 years put together. So clearly this is an issue at all levels that is getting a lot of attention. So I guess my hope would be is that we can start looking at some of those emerging trends coming up. And I would also put in a list there for problem gambling. Again, something that is very sexy and on the news was national sports betting. There just seems to be no end to the ways that we can entice people to spend their money in lots of different ways. And so, again, how can the state agency be kind of at the forefront of some of that and be prepared, such as an opioid settlement act, so that we can direct where some of those monies would be going rather than just in some holes.
So some priorities were recommended around really more leadership and attention around emerging trends related to substance use disorders, and also in the arena of problem gambling, and even to the point of saying, gosh, there might be an opioid settlement. And the state needs to be thinking about that. And then where might those dollars go should that happen? And really being able to be proactive in leading on that and being a voice in that process too. Anyone, Carrie, you have anybody with priorities out there in the field?
Suggestions.
Okay.
I told them we'd add them to our list when we capture
Okay.
the chat at the end of the meeting.
Okay. Anything that you think we might want to share with the room?
Maybe just a suggestion to incentivize more caregivers to provide assistance for people out in rural or frontier areas for services.
All right, so a suggestion from someone who's joined us from another location in the state to ways to incentivize caregivers to provide services in more rural parts of the state. Important issue. Yes.
I think, Madam Secretary, I think you already sort of hit on this a little bit earlier on, but I think it ought to be sort of one of these priorities, and I'll try to encapsulate it a little better. The waiting lists have been used as a political football for a very long time. But what continually comes up, one administration or another will say, well, we'll give this amount of money to eliminate the waiting list or to make this. What needs to happen is a comprehensive plan to address workforce shortages, and the capacity issues that are out there, and the resources necessary, so that the legislature and the executive branch can kind of get on the same page with all, work toward that goal in a cohesive manner.
So really a recommendation, maybe under the context of the waiting list, but recognizing that it's not as simple as, gosh, let's fund the waiting list, or let's fund rates, or let's do this, but really a plan that looks at issues around capacity in the system, workforce, addressing the waiting lists, and addressing, providers. I mean, a comprehensive plan around that. Okay, good. Yes.
Yeah, so for the recent 10 years, there's been a lot of service and programs that have been cut in budgets and stuff that's impacting the deaf and hard of hearing community for a while now. So we need to have a plan and something in action that we can't forget the deaf and hard of hearing community. Because, they don't have access to services and community, and we've been fighting this fight for a long time, and it's impacting everyone, actually. So if they don't get those services, we have to remember the deaf and hard of hearing community needs to have those in place as well. So don't forget about them.
All right, so remembering the deaf and hard of hearing community as we think about kind of this array of services. Thank you.
Yep.
Yes.
We've had an increase in suicide over the past 10 years, and I think we really need to focus on funding our crisis call center here.
All right, so just the comment in terms of priorities has to do with the increase in suicide rates and putting a priority on funding the crisis call center in Kansas. Thank you. Yes.
My suggestion is over the agency-wide increase in transparency and communication with stakeholders. There's been so many times when I've written emails or called or written letters and had no response whatsoever. The other part of it is the transparency. There's been several times when many of us have asked for more information on the funding of IDD, who the MCOs, what their profit is, and we've been told, oh no, that's a secret, that's a contract, we can't tell you this. We are left with very little information to talk with our legislators that is of substance. So transparency across the board and more honest communication with us.
All right.
I'm not saying that this is the Kelly administration. It's our history, the tradition.
Yeah, so really a comment and a recommendation around transparency and open communication, and in this particular circumstance, really from a parent. And I would say, I mean, as you indicated, I think transparency and open communication, I mean, that's really a high value of Governor Kelly, and she's made that very clear to all of us as cabinet secretaries. And I hope folks are beginning to see us demonstrate that. We're not perfect, but we're trying to make progress in that. I do think you also, you call out a piece too, where I think we also have to think about maybe some more effective ways to communicate and get information out there. Folks kind of sit in different seats. It's kind kind of want things for folks hanging around the Capitol all the time, or maybe being connected to a network, an association, or things like that. But I think maybe we have to figure out some ways to be more mindful about, individuals such as parents or even recipients of our services, and how you receive information and how you're able to be responded to. Good input there. In the back.
Thank you, Madam Secretary. This one hopefully would be a fairly simple one. In the past, they did the DD monthly summary reports, and some time ago it scaled down to kind of a one-page on all the waivers, and so it's hard to really. I know a lot of organizations used to use that previous information that have a lot more detail around the ages, how long people have been on, where they're at in the state, and that helped with planning and system optimization. And so I just wanted to throw out there as an idea, and we talked about other circles too, but a return to some sort of additional monthly summary that had more of that previous information.
So the recommendation is to bring back, in this case it was talking about kind of a DD monthly report. I think that may also be true across other systems. I would say that, kind of coming in after being gone for 7 years and and with managed care playing a larger role in terms of long-term services and supports, I have found it as secretary a challenge to find the information I need to make decisions, and that's a conversation. I'm honest about that, and that's a conversation we're having internally and with our partners at KDHE. Is how do we get that? How do we have the information that we need, and then how do we distill that and make that something that's transparent to others? That's been an ongoing conversation.
And I think there's a lot of partners who would be willing to help have that dialogue. So I don't think we're tied to any one format, but just there was a lot of information that was available previously that now just is boiled down to one number every month. And if you want to even look at trends, I got to open 12 or 15 documents, and they only go back 2 years. And so, you don't really have that full picture of what the waiting list has been, what it is, where it's going, any of that.
I think you're kind of preaching to the choir here. So, yeah, I think we've got that captured. All right. Anybody? Yeah.
Somebody asked me to relate that, to talk about the emphasis must go back to children living at home with their families with services. This is one of the reasons people talked about how great Canvas was so many years ago. From what we have learned about trauma and the developmental needs of children, this is more important than it ever was, and we need super coordination between mental health and child welfare.
So the comment has to do with really an emphasis on children living at home with their families and awareness of trauma. And again, with the underneath piece being the intersection between mental health and child welfare. Great comment. Thank you. Anything else in the room? Yes.
So I'm very excited about the projected income level because it's going to allow us to serve more folks and for them to stay in the community where they want to be. And I understand it's a dollar amount right now. Other states have those that actually attached to a percentage. And so as you're doing that capacity strategic planning, I'd like to keep us up to date with where we want to be and where we should be as the state continues to grow. And we have our great governor, and we get more revenue in, and reimbursement rates as well, so that agencies can continue to operate and be fiscally responsible, and that our girl elders and our PD folks and things like that can stay in their homes.
So really a recommendation on the protected income level to maybe tie it to some formula so that it continues to go up, in concert with that, and also sort of a like piece about reimbursement rates. I think those are really good suggestions as well when we move back to thinking about budget and legislation and things like that for next year too. Anybody else in the room? Oh, yes.
The question I have pertains to the final rule for community service providers in Kansas have the CBO attached, which by the final rule is conflict of interest, as in charge case management. Do you have any plans or thoughts on that?
Okay, so the question is regarding the final rule and the potential conflicts of interest between a CDDO and that has a community service provider kind of attached to it, and same with targeted case management. We are, as we've worked through and have been working over the past couple of months with CMS on our IDD waiver, of course, we're trying to reconcile what we believe is coming with, updates for final rule and what maybe some of their guidance might be on conflict of interest. Quite frankly, we're awaiting some additional guidance from them, which is another good reason to kind of hit pause on the waiver renewal, because I think that some of their guidance will help inform some of the conversation that we'll need to have going forward. So it is definitely an issue that's on the radar, and I think that it is something we'll continue to want to have discussions with our stakeholders, whether that's providers, consumers, our CDDO partners on that, to see what kind of impact that might have.
You raised the pause. Has CMS agreed to that pause?
We submitted earlier, let's see, was it late last week? Okay, late last week we submitted an initial request to CMS to extend the existing waiver. They did send us back some additional guidance. They wanted us to rewrite the letter and include some additional data and information about what our plans were, how we, what our timeline might look like. So actually, I spent all afternoon yesterday and all this morning trying to draft a revised letter that tells them what our intentions are as far as meeting with additional stakeholder groups, doing some work groups, and trying to attempt to put together a timeline for what that might look like. Technically, they have not yet provided us that approval. I do, though, believe that they will approve an extension of the waiver. We were very open and clear about the fact that we wanted more time, and they seemed, based on my perspective, to be supportive of that. I will tell you that our mechanism for extending the waiver comes in 90-day increments. So if you see that the state is approved for a 90-day extension, I would just mention that doesn't mean the extension's only going to be 90 days. We've been really clear with CMS as well that in order to go back and do have some of the conversations we need to have, it may take us longer than just a single 90-day extension. There may need to be multiple extensions. So I await. We're hopefully by tomorrow we'll be sending this revised letter with the information to CMS, and then I would hope within the next week we'll have a response from them.
Yeah, the 90 days is applied to this July 1st implementation. So they could, in fact, say, no, you've already submitted.
Technically, yes, they could. However, there is still enough back and forth and enough questions that we have been answering and have been asked by CMS. And quite frankly, that conflict of interest guidance, that was part of what we need from them too, to be able to complete our waiver application. And on all sides, that takes some time. So I think we may have been looking at an extension regardless, just to complete some of the work with CMS, but we're hoping that by asking and kind of laying out our priority to re-engage with stakeholders, that CMS will support that and allow us to take the time we need.
There was a recommendation from someone out at another location to make sure that we're focusing on real self-direction. Other priorities in the room? It won't be your last chance. I mean, like I said, you'll certainly have some opportunities through not just these big processes, but I mean, just in the way that we engage you on an awful lot of the issues and topics that we've talked about. So, one more time.
Madam Secretary, I just wanted to thank you and your folks for embracing the social determinants of health. And I really hope that as we go forward and we're seek creative solutions, that we look at really holistic approaches to supporting people rather than approaches that focus solely on eligibility-based services. I think, with some of the systemic issues that we're facing on a capacity level, we need to become really creative in how we support people in the community.
Thank you. Thank you for that comment. The comment really had to do with the social determinants of health, and how those, in some ways, those really become a frame. And I would actually really credit Deputy Secretary DeBoer for bringing that to the table. And I think it really does help us to think about what we're doing in some different ways. And I think you're right. We are going to have to be creative and thinking differently and sort of outside of some of those boxes, whether they be eligibility, whether they be certain silos. I mean, we've got to be thinking differently. And I think the social determinants of health really help us to do that. Anything else folks would like to get out there before we close? Is anybody on the phone? Going to undo it? I'm going to just undo the phone just for a second. Yeah, one more in the back. How many do you get, Steve? Let's see.
I don't know. This goes back, and this might be a question for Commissioner Penrod on the eligibility. Are there still plans to implement the IDD as an eligibility instrument?
The question is whether we are still planning on implementing the Inter-RAI tool for IDD eligibility, functional eligibility. And we are still working on that project. As you know, it was approximately a year behind some of the other work that we were doing with the other waivers, eligibility tools, but that is still moving forward, and we are still working on it.
So when you say working on it, are you talking about coming up with an eligibility instrument, assessment instrument, or the Inter-RAI specifically? We're still working on that.
There's several components, so it's not only the programming of the tool and making sure we have for assessors that go out those questions and skip patterns in the tool to make it easier for the assessors and less cumbersome for the individuals. There's some technological aspects to it, but then also making sure that the testing and things are appropriate. We're trying to transition from one functional eligibility tool to another, and we want to make sure that it is a smooth and seamless process, which does take some time and testing and.
Have there been any testing in terms of the algorithms that are generated from it and the impact they have on funding of services for people? Because I know in some of the other states that have adopted the Inter-RAI, there have been instances where people's services were drastically cut. And before we look at different eligibility assessment instruments, one of the instruments that have been repeatedly advocated for by advocates was the supports intensity scale. I didn't know if that would be a possibility to be on the table still.
Okay. There has been a lot of testing, and I think that a good deal of testing has been related to ensuring that the scoring is consistent between the same person on the same day having this assessment versus the new tool would score the same. That's been a big focus. As far as the other tool, I would have to go back to my staff and the work groups that have been working on those items and kind of revisit that item with them to see if there's anything else that has been considered or on the table.
My understanding is the reason why the sports intensity scale was not a consideration was the fact that there was an actual cost to using that, although it was a minimal cost per person. And the Inter-I was a free assessment instrument. And I think we were looking at like the IDD waiver, where the average cost on the HCBS waiver is about $50,000 a year per person. A very small upfront cost. We were trying to determine what is really best for a person, what a person actually needs, is, you know, a wise investment if we take a look at that.
Well, I'll ask if Connie, if you can put that on our list as well. I can't make that decision or determination today. But I will certainly go back and talk to my staff and have that conversation about the decisions that had been made in the past and whether any of that needs to be revisited.
Along with that same question, is there a date for implementation for PD and brain injury waiver, changing the assessment tool?
For the PD and FE tools, I do not have an implementation date for that. For the brain injury waiver, we are on track for a July implementation, though it may be mid-July.
I'm saying the assessment tool, not the waiver itself.
Yes.
The assessment tool. Mm-hmm. And has that been field tested?
They have been. They're going to be. They are working on some of that. I can get you some more information about exactly where they're at in that process. I think there is still some testing to be done. I know that there's some training that definitely will need to be done.
I'm just concerned about having a valid and reliable instrument.
I understand.
All right, what else?
Question. Are you going to continue contracting with, we call it the clearinghouse, Maxim, or whatever that contractor is?
All right, the question has to do with the clearinghouse, Maximus. Governor Kelly recommended and the legislature supported a recommendation, let me get some water, that long-term supports and services eligibility be brought back to state workers effective next January, I believe. Now that will still primarily be a clearinghouse model here in Topeka, but it will be state workers as opposed to privatized out to Maximus. Then in addition to that, there will also be some number of those state workers, I think it's 27, that will be located, this hasn't been formally announced yet, but I guess I'm telling you, that will be located in DCF offices across the state. And so that's a little bit of the high touch we were talking about. Now those individuals may not do all of the, complete the whole application, do all the processing, but they'll at least be a resource that someone can come and talk to in the local community, get help filling out that application. So that's kind of the story with the clearinghouse. So that'll be a January implementation. And actually, I think some of the staff will begin to go into the DCF offices later this summer and throughout the fall. All right, I'm gonna say going in just a second. And I would say, I know there may be some individuals who are on the conference phone line who've not been able to see what we're doing here today. And I would ask those individuals, if you have ideas, priorities you'd like to make sure we put on our list, and we'd love you to email those to us. I think I'll have them email them to you, Connie. So your email, connie.hubble. Okay, I'm going to make Connie come up here and... She doesn't trust me to spell. She doesn't trust me to spell her name. I really know how your name is spelled.
Anybody on the phone or anybody in here, if you have other issues you'd like us to carry forward, it's Connie.Hubble, HUBBELL @ks.gov.
2 B's, 2 L's. Yeah.
2 B's in Hub and Bell.
Yeah, 2 B's and 2 L's. Yeah, Hub and Bell. I
And I'll
didn't think
pass
about
it
it
on,
that way.
yes.
Yeah, and so we'll collect those as well. And I think the question has also been asked: can we make kind of these lists of priorities available? And we can sure find a way to do that. So absolutely. All right. Well, thank you very much for coming. This has been incredibly helpful. I mean, to not just to share things that happen, but mainly to hear your perspectives. So thank you for taking the time. We're going to take this back, and we're actually doing some additional internal planning, doing a little bit of kind of strategic thinking about priorities, and it really helps us to know those things where you said, I didn't hear that, or gosh, that really was a good idea. So thank you so much. This will inform us not just now, but as we also go through the future and begin to think about, agendas, not just for the months to come, but even after that time. So again, look for us. We'll find a way to make this information available to you, and then we'll also be reaching out in a global way again, as I said, probably in the August timeframe around input on budget priorities and legislative priorities. We'll have to turn in our budget by September 15th, so we'll be eager to get some more input from you before that timeframe. So again, thank you very much. We really appreciate it. So take care. Travel safely home. Thank you.
Help yourself.
Even though there was, oh yeah.